So today, we would like to thank you all for joining. And then tonight we will be discussing stenting and angioplasty with protection in patients at high risk for endarterectomy, otherwise known as the SAPPHIRE trial. And I'll pass it on to Elizabeth to get us started.
Hi, everyone. Next slide, please. We just want to let everyone know that this meeting will be recorded tonight. Okay, so we're going to jump in. This is just a profile of our attendees tonight. Thank you all for joining. The majority is MS2 and MS3 participants, but we have a little bit of a mix of everybody. So happy to have everyone here. Okay, and we'll get started by introducing ourselves. My name is Elizabeth Lavanga, and I'm a third-year medical student at Penn State College of Medicine. I will be applying into integrated vascular surgery in the upcoming match cycle.
And then, hi everyone, I'm Nabiha. I'm currently finishing off my third year at Loyola University Chicago's Church School of Medicine. And I have the pleasure of introducing our amazing attending panelists on the next slide. And I'll start off with Dr. Wohlauer. Dr. Wohlauer holds the position of Associate Professor of Surgery within the Division of Vascular Surgery at the University of Colorado School of Medicine. Additionally, he fulfills the role of Medical Director for the Surgical Inpatient Units at University of Colorado Hospital and serves as the Medical Director of the Vascular Lab at the same institution. He also acts as the Associate Program Director for both the Vascular Surgery Fellowship and the Integrated Vascular Residency programs. Dr. Wohlauer's academic journey includes a 2-year NIH Trauma Research Fellowship between 2009 and 2010 under the mentorship of Dr. Ernest Jean Moore at the University of Colorado. With over 86 peer-reviewed manuscripts and 6 book chapters to his credit, his scholarly contributions are substantial. His clinical interests center around investigating coagulation and platelet function to enhance outcomes for patients with peripheral vascular disease. Beyond his clinical and research pursuits, Dr. Wohlauer is deeply engaged in resident education initiatives to promote patient safety and advocating for the health and wellness of vascular surgeons. Dr. Wohlauer, if you would like to say hi and introduce yourself.
Thank you, Ms. Khan. And this is my pleasure. I really look forward to participating tonight.
And now I'll pass it on to Elizabeth to introduce our next attending panelist.
Thank you. I have the honor of introducing Dr. Hayek. Dr. Hayek is an assistant professor in vascular surgery at Washington University in St. Louis. She has a diverse educational background, having completed her undergraduate studies at WashU, followed by a Master of Science in Nutrition at Columbia University in New York City. Dr. Hayek obtained her medical degree from the University of Queensland Ochsner program, with training split between Brisbane, Australia, and New Orleans, Louisiana. Following medical school, Dr. Hayek pursued her general surgery residency at Ochsner in New Orleans, where she gained extensive experience in surgical care. She then went on to complete her vascular surgery fellowship at WashU in St. Louis, further honing her skills in the specialized field of vascular surgery. Dr. Hayek, if you would like to introduce yourself and say hi.
Hi, everyone. I'm Genevieve. I'm very excited to be here. I'm the new chair for the VESS Student Education Committee, so I'm really excited to be participating in this and see what it's all about. So happy to be here.
All right. For those of you who may not be familiar with our organization, the VESS VSIG was started as a national forum for students interested in vascular surgery, specifically focusing on students at institutions with no home VSIG program to receive continued vascular exposure and mentorship. This event is brought to you by the VESS VSIG Journal Club team. We are proud to present our third installment of the Journal Club series, and today we will be focusing on the SAPPHIRE trial. Okay, so we're going to jump in a little bit with carotid anatomy and carotid disease. We'll start from left to right as I describe the photos above. The common carotid artery emerges directly off of the aortic arch on the left and most commonly off of the brachiocephalic trunk on the right side, although there are anatomic variations in branching. It then travels into the neck, where it branches into the external carotid artery and the internal carotid artery. The external carotid artery has many branches, which supply the facial muscles, tongue, and scalp. The internal carotid artery dives into the skull via the carotid canal to feed the circle of Willis, which is the photo on the right. Next slide. We'll now talk a bit about carotid disease history and pathophysiology. Carotid disease results from the buildup of fibrofatty plaques due to damage of the arterial intima. This buildup impedes laminar blood flow to the brain. The degree of carotid stenosis, defined as a percentage of the lumen occluded, is associated with increasing levels of stroke risk and is strongly correlated with the level of benefit from intervention. The vulnerability of the plaque, defined by the presence or absence of a fibrous cap, necrotic center, and inflammatory infiltrate, contributes to the risk of embolization and rupture. Carotid atherosclerosis can cause stroke and TIA or transient ischemic attack pathology via either embolization of fibrofatty plaque pieces or hypoperfusion, although hypoperfusion is rare and typically only occurs when there is significant occlusion of both the carotid and vertebral arteries. Each year in the United States, approximately 800,000 people experience new or recurrent stroke. And until 1905, all strokes were believed to arise from intracranial pathology. However, approximately 20% of strokes result from embolization, either from the heart or carotid vessels. Dr. Chiari was the first to describe the possibility that stroke pathology may arise from atheroembolism from extracranial vessels, such as the common and internal carotid arteries. The first carotid endarterectomy, however, was not performed for another 50 years when Dr. DeBakey bypassed a plaque from the common carotid to the ICA, or internal carotid artery. We will discuss methods of carotid disease management in a later slide. We will now move on to discuss symptomatology. Patients may either present to a vascular surgeon's office for evaluation of carotid disease with residual neurologic deficits from a stroke or incidental findings from a primary care physician's exam, or even as a result of unrelated head and neck imaging. Symptoms and historical information suggestive of carotid pathology include, number one, episodes of loss of consciousness, which may be suggestive of global ischemia. Two, amaurosis fugax, which is a fancy way of saying transient losses of vision in one eye as a result of embolization to the ophthalmic artery, which is a branch of the internal carotid. Many patients will describe this as an acute onset loss of vision, similar to a curtain descending over their visual fields. And number three, cognitive decline. This is somewhat of a controversial relationship. However, it is believed that patients with both symptomatic and asymptomatic carotid disease may be at an increased risk for progressive cognitive decline due to repeated microinfarctions and decreased perfusion to the brain. And lastly, a vascular surgeon should perform a full neurologic exam, including evaluation of cranial nerves, muscular strength, sensation, cognition, cerebellar signs, and gait. Auscultation of the neck may or may not demonstrate a carotid bruit according to the extent of the disease and the blood pressure of the patient. We'll now try to listen to a video of what a carotid bruit would sound like. The video may be a bit quiet to hear, but if you are interested in learning more, you can just search this up on YouTube, sound of a carotid bruit, or maybe you'll even hear one in clinic yourself. I'll now turn it over to Nabiha to talk a little bit about duplex ultrasounds.
Hi, please. Thank you. We will now get into imaging for carotid artery disease. So we'll start with the carotid ultrasound, which is a non-invasive test which uses sound waves to create images of the carotid arteries and visualize blood flow patterns in real time. Some of the diagnostic features of this imaging is that it allows for measurement of peak systolic velocity and end diastolic velocity. It allows for calculation of the carotid artery stenosis using velocity criteria, and it allows for visualization of plaque morphology and ulceration. The clinical utility of this is that it's a screening tool for asymptomatic patients at risk. It allows for preoperative assessment for carotid endarterectomy or carotid artery stenting, which we'll get into a little later, and it allows for monitoring disease progression and treatment efficacy. It's readily available, it has a high sensitivity and specificity in detecting carotid artery disease, and it's cost-effective compared to other imaging modalities. For some limitations is that it depends on the operator and variability. There's suboptimal image quality in obese or heavily calcified patients, and there's an inability to assess the distal internal carotid artery beyond the skull base. But otherwise, it is one of the first-line imaging for carotid artery disease. Going into the next slide. For here, we'll talk about computed tomography angiography, otherwise known as CTA, which involves contrast media injection and taking multiple X-ray images to create cross-sectional pictures of the blood vessels. This provides detailed visualization of carotid artery anatomy and stenosis and high spatial resolution and rapid acquisition. And then we also have magnetic resonance angiogram, which otherwise is known as MRI, and this uses magnetic fields and radio waves to produce multidimensional images of carotid arteries without ionizing radiation. It's an excellent soft tissue contrast and assessment of plaque composition. Some of the indications for using these are the confirmation of carotid artery stenosis detected on initial ultrasound, preoperative planning, and evaluation of collateral circulation and distal vasculature. Some of the advantages of this are that it offers a comprehensive assessment of the vessel lumen, plaque morphology, and adjacent structures, and it's a non-invasive alternative to the conventional angiography. Some of the limitations are contrast administration contraindicated for patients with renal impairment or contrast allergies, and it requires specialized equipment and trained personnel, so there may be a limited availability in some healthcare settings. In the next slide, we'll talk about diagnostic angiography, which is an invasive imaging technique that involves catheterization and contrast media injection, allowing for direct visualization of carotid arteries and surrounding vasculature, as well as real-time assessment of the blood flow and arterial morphology. The indications of this are to confirm the severity and extent of carotid artery stenosis, assess collateral circulation in the distal vasculature, and for preoperative planning. Some of the advantages of this is that it offers high spatial resolution with detailed visualization of the arterial anatomy, as well as the potential for therapeutic intervention during the same procedure. Some of the limitations include that it is an invasive procedure, so vascular injury and contrast-induced nephropathy are risks. It requires specialized equipment and expertise, and the increased cost and longer hospital stay compared to the non-invasive imaging modalities. Selection of imaging modality are based on patient factors, the clinical scenario, and institutional resources that are available. We'll go into the next slide to discuss the screening guidelines. So to discuss some screening guidelines, we'll look at the 2021 SVS Clinical Practice Guidelines, which outlines the following recommendations. In asymptomatic patients who qualify for carotid artery stenosis screening, duplex ultrasound is the recommended choice over CTA, MRA, or other imaging modalities. Routine screening is not recommended for clinically asymptomatic carotid artery stenosis in individuals with significant risk factors for carotid disease. It's not recommended for clinically asymptomatic individuals without significant risk factors, but it is recommended for high-risk groups, which includes lower extremity peripheral artery disease, if they're undergoing a CABG, if they're over the age of 55 with 2 or more traditional atherosclerotic risk factors, if they're actively smoking, if they have diabetes, hypertension, or coronary artery disease, or if they have clinically occult cerebral infarction noted on brain imaging, or if they have a carotid bruit, which we heard on Elizabeth's last slide. The prevalence of carotid stenosis increases with the number of risk factors that are present. To go into treatment, optimal medical management requires a thorough assessment of each patient's individual risk, taking into account factors such as comorbidities and adherence to treatment. While acknowledging the distinct requirements of each patient, some general recommendations for optimal medical management of arterial disease include lifestyle modifications, such as smoking cessation and dietary adjustment, as well as medical interventions like antiplatelet therapy, statins, and blood pressure medications. Now to get into the surgical and endovascular treatments for carotid artery disease. Since the 1950s, carotid endarterectomy has been used to treat carotid artery disease. It involves removing plaque from the artery and patching it up to prevent further narrowing. During the procedure, patients may be monitored using tests like EEG or transcranial Doppler, or they might be kept awake to monitor their motor response. The surgery can be done with or without using an arterial shunt to maintain blood flow to the brain. Risks include cardiopulmonary risk of acute myocardial ischemia, a small perioperative risk of neurological events, neck hematoma, or potential damages to nerves in the neck affecting functions like swallowing or speech. Next, we'll get into the transfemoral carotid artery stenting, which involves inserting a stent into the carotid artery through the femoral artery, but it needs protection from embolization. This can be done using a filter or flow arrest procedure to stop bits of plaque from reaching the brain during the procedure. And then lastly, we have the transcarotid artery revascularization, otherwise known as the TCAR, which is a newer technique that avoids manipulating the aortic arch. Instead, the common carotid artery is exposed directly and a sheath is placed to allow for stent delivery, which you can see in this little video above. The sheath is connected to a vein sheath in the leg, causing blood flow to flow in reverse across the artery where a filter catches any debris before it reaches the brain. TCAR has a lower risk of stroke compared to the transfemoral approach because it avoids certain manipulations that can cause embolism. However, because TCAR is relatively new, long-term data on its effectiveness is still limited. Anesthesia for carotid endarterectomy typically involves regional techniques such as cervical plexus blocks or general anesthesia, while carotid artery stenting is often performed under conscious sedation or local anesthesia with monitored anesthesia care. Now I'm going to pass it off to Elizabeth to actually get into the trial.
So we just took the past couple of minutes to learn a little bit about carotid disease, and now we're going to be able to apply it to the SAPPHIRE trial itself. So next slide, please. This is just an image of the New England Journal of Medicine publication titled Protected Carotid Artery Stenting versus Endarterectomy in High-Risk Patients, and the many number of incredible authors listed below. Okay, so we're going to start with a little bit of background on carotid stenting. Carotid stenting is often employed for patients considered to be high risk for carotid endarterectomy, defined as having a high lesion above C2, having a history of head and neck radiation, or recurrent stenosis. The utility of the stenting approach increased with the invention of crush-resistant nickel titanium stents, as well as emboli protection devices. And the figure on the left shows you a number of different industry devices for embolization protection. Now, the NASCET trial, or the North American Symptomatic Carotid Endarterectomy Trial, and the ACAS trial, known as Asymptomatic Carotid Atherosclerosis Study, both evaluated stroke risk reduction for patients undergoing carotid endarterectomy with medical therapy versus medical therapy alone. NASCET focused primarily on symptomatic carotid patients, while ACAS focused on asymptomatic patients. And although both trials reported stroke risk reduction with the use of endarterectomy, they both excluded very high-risk patients and therefore may have overestimated the improved outcomes of those who underwent carotid endarterectomy. These trials also did not address carotid stenting as a method of intervention. Therefore, the SAPPHIRE trial team sought to address the knowledge gap left by prior landmark trials. They developed the hypothesis that carotid stenting was not inferior to carotid endarterectomy. They went about studying this via a randomized controlled trial, which involved 29 different sites. Center investigators went through a strict vetting process involving a review of their carotid stenting numbers, the median of which was 30 patients, and certain outcomes. Risk of periprocedural stroke and death must be less than 6% for them to be included as center investigators. Patients were then selected on the selection criteria listed: symptomatic stenosis of greater than or equal to 50%, or asymptomatic of greater than or equal to 80%. Additionally, all patients enrolled must have had one coexisting condition which caused them to be high risk in the CEA category. So those risk factors are listed in the box in the upper right-hand corner. Notably, patients over 80 were included as high risk, and those patients were excluded from the prior NASCET and ACAS trials. Patients were then assigned to the treatment groups in a 1-to-1 ratio. On the next slide, we're going to discuss the timeline. So first, 747 patients were recruited across all the different sites, and they underwent a thorough review process of their surgical and anatomical factors by both a surgeon and an interventionalist. Recruitment occurred from 2000 to 2002, but was terminated in 2002 due to a significant decline in enrollment resulting from carotid stent registry availability. 334 of these patients were then assigned randomly to their treatment group. Patients in both arms received aspirin 72 hours preoperatively, while patients assigned to the stenting group also received clopidogrel 24 hours pre-op. However, the stenting group, the carotid endarterectomy group did not receive clopidogrel due to the increased bleeding risk. If the patient underwent stenting, the stent used was the SMART or Precise Cordis stents, which is pictured on the left. That's the Precise Cordis stent. And they used the AngioGuard or AngioGuard XR Cordis embolization protection devices. Follow-up for both groups then occurred at 30 days, 6 months, and 1 year postoperatively. So for outcomes, the primary endpoint of the study was the incidence of major cardiovascular events at 1 year. This included a composite of death, stroke, and myocardial infarction at 30 days and ipsilateral or same-side strokes thereafter. Secondary endpoints included the need for revascularization at 1 year, cranial nerve palsies, and site complications. So discussing the demographics, they included their demographics in Table 2. Demographic characteristics between the carotid endarterectomy and stenting group were largely similar, except for a high frequency of coronary artery disease and prior percutaneous transluminal coronary angioplasties, which are highlighted in the red boxes there, and those were increased in the stenting group. Okay, and then we'll start off with their results based on outcomes. So in Table 3, were included the 1-year results. Analysis was completed in 2 different fashions. On the left-hand side, we have the intention to treat analysis, which essentially just means that they included everyone who was originally enrolled in the study, even those who dropped out. And then actual treatment, which is also known as per protocol, which meant that they analyzed only those who completed their assigned treatments and made it to all of the follow-ups. Intention to treat is a more conservative estimate of the effects of results, while actual treatment method is a perfect world scenario and tends to overestimate the findings of the study. Therefore, we'll primarily discuss the intention to treat results as we move forward. Now, when we take a look at the primary endpoint, which is the very bottom of the table there, highlighted in a red box, 20 stent patients and 32 carotid endarterectomy patients experienced the primary composite outcome, which was a nearly statistically significant difference. They did set their alpha level at 0.05, and the p-values for both intention to treat and actual treatment analysis were 0.05 in this case. When we take a look at the secondary outcomes, also highlighted in red boxes there, the carotid endarterectomy was more likely to experience cranial nerve palsies and target vessel revascularizations. Okay. The next table, Table 4, was the results at 30 days. At 30 days, there were no statistically significant differences between 2 groups in the intention to treat analysis. However, length of stay was also analyzed at this time point, and it was found that carotid endarterectomy patients had a statistically significant greater length of stay at about 2.85 days in comparison to the 1.84 of the stent group, which was interesting. Okay. And lastly, here we have the figure that they included. Figure 1 represents freedom from major adverse events at 1 year. The top figure, 1A there, is the intention to treat analysis, and this demonstrated an insignificant difference statistically between event-free survival between groups. The stent group was about 87.8, whereas the endarterectomy group was 79.9, and the p-value was 0.053. When we take a look at the bottom figure, 1B, this is the per protocol or actual treatment analysis, and this demonstrated a weakly significant difference with a higher rate in the stent group. So coming to our conclusions, the study determined that the incidence of the primary endpoint was 39% lower in the stent group. Additionally, bleeding complication rates were similar between the groups, and carotid endarterectomy has actually had an increased risk of cranial nerve palsies and length of stay. Therefore, the study supported their hypothesis that carotid stenting is non-inferior to endarterectomy. Now, in taking this paper as a whole and looking at some of the considerations in order to fully understand their results, study neurologists assessed patients within 24 hours of their intervention, therefore catching more small strokes than would likely have been identified in a less controlled hospital setting. Also, patients were removed from the trial as a result of inability to meet eligibility criteria, deterioration of condition, and withdrawal of consent. However, this limitation was somewhat accounted for by the study's dual approach to analysis. Finally, this study was sponsored in part by Cordis, and therefore all stents used were Cordis made. This industry sponsorship introduces bias. This bias was somewhat offset, however, by the use of impartial analysts and frequent data reporting. I'll now turn it over to Nabiha to do the long-term assessment of outcomes.
Okay, This was published in 2008. So as the primary clinical advantage of carotid revascularization lies its ability to mitigate the risk of future stroke, it's important to compare the long-term outcomes between the two approaches. Therefore, it's important that we discuss the 3-year update of primary and secondary outcomes within the randomized cohort of the SAPPHIRE trial. So to discuss the results, we'll start with in table 1 on the left, that displays the major adverse events through the 3-year cutoff point, and there was no statistically significant difference between the stenting or endarterectomy group. On the right, in the panel A of the figure, we can see that about 74% of patients in the stenting group and 70% in the endarterectomy group were free of major adverse events at 3 years, with the pre-specified major endpoint defined as death, MI, or stroke within 30 days, or death or ipsilateral stroke between 31 days and 1,080 days as the 3-year cutoff. In panel B, 80% of patients in the stenting group and around 76% in the endarterectomy group were alive at 3 years. And lastly, in panel C, a total of 92% of patients in the stenting group and 93% in the endarterectomy group were free of stroke at 3 years, defined as stroke within 30 days or ipsilateral stroke between the 31 days and the 1,080 days. So going into the conclusions on the next slide, in their trial of patients with severe carotid artery stenosis and increased surgical risk, there was no significant difference that could be shown in the long-term outcomes between patients who underwent carotid artery stenting with an emboli protection device and those who underwent endarterectomy. Their key finding at 3 years showed the continued efficacy in preventing stroke and adverse events, sustained safety profile with low rates of procedural complications, and similar long-term outcomes, including restenosis rates and overall survival. Some of the implications of the study are that it provides evidence for the durability and effectiveness of carotid artery stenosis in the high-risk patients, and it informs clinical decision-making in the management of carotid artery disease. The absence of a medical therapy group presents direct comparison of safety and efficacy outcomes with patients receiving current antithrombotic or lipid-lowering therapies was one of the considerations or limitations of this study, and then also the fact that there's a lack of insight into outcomes of treating carotid artery stenosis in patients at low to moderate risk. So the SAPPHIRE 3-year update contributes valuable evidence to inform shared decision-making regarding the management of carotid artery disease in high-risk patients. And while the trial demonstrates the long-term safety and efficacy of carotid artery stentings, clinicians have to consider individual patient factors, preferences, and institutional expertise when selecting the most appropriate treatment approach. Going into the next slide. What's important to note is that carotid disease stands out as one of the most well-studied pathologies in vascular surgery due to the extensive use of randomized control trials, which systematically compare interventions such as endarterectomy and stenting, allowing for robust conclusions on efficacy and safety to inform clinical practice. SAPPHIRE being the first of its kind in the modern vascular era, focusing on high-risk patients and displaying results favoring carotid artery stenting, predominantly based on the lower rate of peri-procedural MI. Nevertheless, the results of the trial established the indication for carotid artery stenting in patients at high risk for surgery. This trial was the launching point for many other trials, with CREST, a randomized control trial comparing carotid endarterectomy and carotid artery stenting in patients with symptomatic and asymptomatic carotid artery stenosis using the emboli protection devices and experienced centers being the most informative study thus far. They found similar long-term outcomes for both interventions, but suggested that younger patients may benefit more from carotid artery stenting, while older patients might fare better with carotid endarterectomy. Our next journal club will be focusing more on the CREST trial, but just to understand the importance, we also have the CREST True trial, which was initiated in 2014 and is ongoing and is a follow-up trial focusing specifically on asymptomatic patients with carotid artery stenosis. It compares carotid endarterectomy and carotid artery stenosis with contemporary medical therapy alone, aiming to determine the optimal medical management strategy for preventing strokes in this population. Ongoing research and updates from larger trials further refine our understanding of the optimal management strategies for carotid artery disease. And so now we'll get into the questions and discussion towards our attending panelists. And I'll pass it on to Elizabeth.
Thank you so much, Nabiha. To all of our attendees, if you guys do have any questions about what we discussed in terms of carotid disease and management, or more specifically about the trial, please feel free to enter them in the chat, and we'll try to get to them as we go through the discussion. We are now going to open it up to our attending panelists by starting off with how do you guys use the SAPPHIRE trial to make decisions about carotid management in your patients today?
Go ahead, Dr. Hayek, if you'd like to start.
Sure. I mean, to be perfectly honest, I don't do a ton of transfemoral carotid stenting, Dr. Wallauer. I don't know if that's a big part of your practice.
No.
To be honest, I mean, in 2 years of vascular training, I think I saw maybe 2 or 3 done. I think TCAR's kind of largely replaced it, but what I think it shows you is that when you're having these conversations with your patients, because everyone wants to know percentages, at least in my experience, because you can kind of quote them, oh, it's safe or it's this, and they want to know. And so, at least now you have data to reassure them that, by putting in a stent, like we talked about, it's not inferior to a carotid endarterectomy, which is kind of, the go-to gold standard. And so I would use it more so in, obviously you have your high-risk patients that you would choose for your carotid artery stenting, which ones that those are going to kind of fall into that category. And I think having data like this, just helps to support and reassure you that you are doing an intervention that isn't necessarily going to be something, subpar, I guess you could say, when you're comparing it to an endart, and also just helps to give you that information that you can then, share with your patients, kind of informing them of your decision making. And that's kind of how I would incorporate, something like this into my practice personally.
I agree. I didn't do a ton of transfemoral carotid stents in fellowship. I think what the take-home message is in terms of safety is that a stent in the carotid artery had reasonable long-term durability. If you flash back to, when this trial was performed, the experienced operators that were in this trial had good results. In my practice, and we could talk about the results because the primary endpoint and the adverse event rate was quite high in both groups. I think the take-home message for me is before TCAR with high-risk patients, even with a contralateral carotid occlusion, I would offer a CEA. With a shunt. I routinely shunt. I'm not sure what your practice is, Dr. Hayek.
I routinely shunt too. That was one of the pieces of advice I kind of got as a new attending, and I'm at a little bit more of a community hospital now. So from a technical standpoint, it makes things easier. It just lets you relax a little bit in the OR. So
yeah. So I mean, I have a patient that if we were in the era of this trial would have been randomized, considered high risk, who was referred to me with a contralateral carotid occlusion and came from another state, drove down, and I did his endarterectomy, and he's doing quite well. And every year he comes down, he's grateful, and he tells me all the things he's able to do. And the duplex, it's wide open every year, wide open. It's a durable operation, and it's something to consider. If you go back to this study and when it was performed, these were patients that were considered high risk for CEA. Also, if they were considered prohibitive risk, they ended up in a registry. If there was equipoise, they were randomized. And that's a hard thing to do. You have surgeons that have a bias towards endarterectomy and interventionalists in this trial that have a bias towards carotid stent, and they're all good at what they do. And to be able to sit down at the table and agree that there's equipoise, that you could randomize the patients into this trial, is a strength of the study and the kind of vigor of the study.
Thank you. In discussing a little bit more about the risk factors that they listed, do you both feel that these risk factors are the criteria that you would use to select patients for stenting? Do you see some of these more frequently in basing your decisions? Kind of what is your take on their selection?
Well, I can start. Patients with carotid disease are high risk. So the additional elements of high risk in this in high risk is defined differently in the various carotid stenting trials. So CHF, COPD, our relative contraindications, age greater than 80 is, it's physiologic age these days, not chronologic age. So you can have two 80-year-olds that look a lot different in terms of fitness for surgery. The laryngeal nerve palsy is a real consideration if you contralateral laryngeal nerve palsy, previous neck surgery, and really neck irradiation, I think is a real risk. And then carotid restenosis, just the scar tissue and the risk of reintervention through surgery. So I don't think all those risk factors are created equally.
I would agree with that, especially the age thing, which, I'm in my like second year of practice, and it's pretty interesting how like you said, not all 80-year-olds are created the same. And, some of them will walk into your office and you're like, oh my gosh, I thought they were 65. They're a lot more sprightly. And just in my discussions, I've talked to a lot of primary care providers because they send a lot of people to my office for, asymptomatic carotid artery stenosis. And it always makes me feel a little icky, operating on, an 87-year-old, but when they're driving and they're independent and they're, taking care of their house and mowing their lawn, it's hard to turn someone down who's got, a 90% stenosis, and according to their PCP is, going to live for another, 3 to 5 years easy. And so like, I agree, not all risk factors are created equal, but I do take all of those into consideration when I'm kind of considering a whole patient. And what approach, especially the previous neck radiation and scar tissue, and the recurrent nerve injury, I think is a huge one. That I, definitely, that all kind of comes into play when I'm personally making my decisions for how to approach a carotid.
Another aspect of the paper that we wanted to get your take on was their definition of myocardial infarction. They used a primarily biochemical test-based approach, and we wanted to learn kind of what you thought of that. Was that more clinically or more laboratory and statistic relevant?
I think it's an important consideration because if you look at the patients that had a true MI, had a STEMI, there were 2 in the CEA group and 0 in the stent group. So those numbers were extremely low. One of the takeaways from this trial was that, CEA has a higher MI rate, and then carotid stenting has a higher stroke rate from crossing the arch in some of these early trials. Is a biochemical, an NSTEMI in a patient who's asymptomatic, is that the same as someone who had a STEMI? I don't think so. I think I want to open this up to Dr. Hayek and to our audience. I think one of the advantages of doing whether it's TCAR or transfemoral stent is to do it under sedation versus, at least in my practice, a carotid endarterectomy requires general anesthesia. And the hemodynamic kind of derangements during that general anesthesia does put patients who are high risk at risk, increased stress on their heart. And we can't monitor for any stroke symptoms like we could when they're under sedation. Dr. Hayek, what are your thoughts?
So I would agree with that. I personally have never done one. Well, I take that back. I had in residency, they definitely did a few carotids under sedation just with local blocks. And then when I think we did one in fellowship, and it can go either way as far as you know, how things go. And it's interesting because at WashU, where I trained, apparently, you know, SAPPHIRE did all of them awake. And so you talk to the guys who've been there for 30 years and they all talk about how miserable the experience was, because I guess the block only goes so high. And so when you're dissecting really high, the patients can actually become very uncomfortable. And so everyone just does it under general. And one discussion I've actually had with anesthesia, not infrequently, is about that. And a lot of times what I've found is that they actually prefer to put them to sleep because they feel like they have more control over the hemodynamic shifts with general anesthesia than they do, let's say, with just like propofol or a block. So I think it's a lot. You have to know your anesthesiologist and your team and, you know, trust them and communicate with them and you know, I don't know where I was going with this train of thought. Sorry, it's been a really long day in the OR, but that's kind of how I've approached it just over the past year and a half. Is I talk very openly with my anesthesiologist and you know, I feel like as long as there's been communication with them and with the cardiologist, I've been able to take people who don't have an ideal, you know, cardiac history, because a lot of them come in with symptomatic carotids. And so I've had to take people to the OR that I wouldn't necessarily choose to. And they've all done okay. But again, there's a lot of communication and just kind of controlling for what you can control for in the OR. I don't know if that helps, but.
Absolutely. One question I have, if I, could ask the original investigators, because future Dr. Lavanga and future Dr. Khan mentioned, this is the high primary adverse event rate in SAPPHIRE for carotid stenting, 12.2% versus 20% in the CA group. So are we talking, major stroke, clinically relevant MI, death is death for the stroke rate and the MI rate, which would really move the needle in these groups. If you look at other contemporary studies or, most surgeon or interventionalists practice, if you had a 12.2 or 20% adverse event rate, I mean, that's really prohibitive risk.
Absolutely. And just to follow up with our discussion of anesthesia practice, I want to read Dr. Hahn's question from the chat. Do either of you do your TCAR awake or under general?
I personally do them all under general.
I do all of them awake. And Precedex is the key. Under propofol, they get disinhibited and it's a wild ride, hemodynamic wild ride too.
Another discussion we wanted to focus on was the industry sponsorship of the trial. What are your thoughts on its influence of trial results? Was it necessary? What are your thoughts on industry sponsorship in general in research of vascular surgery?
I'm going to tackle that first. Do you want me to?
Oh, sorry. I thought you said I'm going to tackle that first.
No, do you want to?
Sure. That's an excellent question. And I think with vascular in general, we use so many devices that I don't think you can get away with, or get away from it, I should say, from industry sponsorship. And I think it can be, as long as the studies are done right and, appropriately, and they take, scientific method and, the results aren't necessarily biased, it can at least give you a good idea of, certain equipment and how it works, as opposed to having, studies where people are using all different filters and stents. And, so in a way, like there's a uniformity, I think, that it kind of provides that helps at least, me be a little bit more comfortable with kind of the results. That being said, like, obviously there's always going to be concern that there, is bias there, just given the fact that they are sponsoring it. But a little bit, I feel like it's a necessary evil. I don't know, Dr. Waller, what your thoughts are on that.
So we talked about this a little bit during our dry run, and I think so. First of all, the industry partnership, I think it is a partnership. If you can recognize the conflict of interest, be aware of it, be upfront about it, I think that's key. We've had some other industry sponsored trials that have been critiqued in the past, the drug-eluting stent trials, lower extremity trials, where there was a lot of patients lost to follow-up and some other issues with the performance of those trials. So I talked to one of the investigators or one of the participants in the trial, my division chief, who enrolled over 100 patients in this trial. And I asked him if he thought what he thought about the conduction of the trial, and he thought it was really vigorous. And if you look at some of the kind of reading of analysis of the trial, they had this independent monitoring that our moderators mentioned, and it was rigorous. So I don't think you can eliminate the fact that the first author was also the inventor of the embolic protection device that was used in the trial, and that several of the co-authors and leads of the study were like part of Cordis. They were received some financial support from Cordis. So that conflict of interest is there. The question is, did it determine or influence the results? And I think it sounds like they made it hard for that to influence the results. They tried really hard to have this independent monitor, neurologist, other assessment to kind of counter that potential conflict of interest.
Thank you. We also have a question in the chat that I can read out to you guys. Caroline asks, the study looked at patients at high risk, which includes asymptomatic patients with greater than 80% stenosis. I believe SVS guidelines are for intervention with stenosis greater than 70%. Where do you find yourself offering surgery for asymptomatic patients in your practice, and how have you made that choice?
So I personally, I go with more closer to an 80% stenosis. I look more at end-diastolic velocity criteria, not necessarily just PSV. I mean, really, I kind of look at all values. And, part of that is with the introduction of statin medications and plaque stabilization, we don't really have, that's what the new trials are for, is to see how exactly that's sort of impacting thing. And so just for me personally, again, being a new attending, your biggest concern or one of my biggest fears is having, doing an asymptomatic carotid and having a stroke from it. And so, I think, pushing the envelope a little bit, not pushing the envelope. I think most people wait until about 80% stenosis for an asymptomatic carotid to intervene. Just kind of helps you justify it a little bit better. And that was, again, it was, just kind of listening to my attendings and fellowship and, seeing how other people practice. It was that kind of seemed across the board what most people did. And so seemed good enough for me when I started out, as and just new in my career. So that was kind of how I approached it.
I agree. So I think for patients who are asymptomatic, they need to be greater than 80%. If they're greater than 80 years old and high risk and asymptomatic, I don't offer them an intervention, or I'd be hard pressed to, because I think with medical management and with those risks, that the risk tends to outweigh the benefit. Having said that, there's some trials. There's a study, a big cohort study from England. PJ Howard, Dr. Howard is the lead on that. And basically the take-home point of that study is that asymptomatic high grade asymptomatic carotid disease, the stroke rate is unpredictable, and it occurs in spite of maximal medical therapy. So somebody that's low risk, reasonable risk for surgery, I do offer them an intervention. And the reason is because with medical management, when you get to that degree of stenosis, the patients that have stroke, they have it in an unpredictable rate. And so it's hard to, you can't eliminate their stroke risk even with the medications that we have and the advances we have with medical therapy.
Thank you. We probably have time for about one or two more questions. We do have another in the chat by Daniel. He said, there is some commentary surrounding the heterogeneity of the trials cohort being a limitation, with a large percentage of patients being asymptomatic or suffering from recurrent stenosis. How do vascular surgeons take this into account when applying this trial to their practice?
I think with the pooled, if you look at the pooled trials, pooled data of the carotid stenting trials, it shows that in experienced hands, the carotid stenting is durable and safe. I think the limitation is having that granular data. So intervening for recurrent carotid stenosis, or comparing asymptomatic versus symptomatic carotid stenosis and pooling all the data certainly has its drawbacks because they're not the same patients, not the same disease.
Yeah, I would basically, not to read, just I agree with everything that Dr. Wallauer just said about that.
And I think for our last question, I'm kind of going to put you guys on the spot here since we didn't ask you ahead of time, but I'd like to know what your idea would be of what you would want future research in carotid disease to look like.
Well, do you want to go first?
I don't know. That's a good question. I'm thinking about it.
Yeah.
I mean, I think the medical management question is a big one for me, just with the introduction of these new medications, how do they affect things? And, like you were saying, just with the unpredictability, even with the medications, like, I don't know. I think looking more at that, I think long-term data from, you know, TCAR will be very interesting with how it plays in everything, 10 years down the road, 15 years down the road. I don't know. I gotta think about that one for a second.
It's a great question.
Yeah.
I think having more information to define stroke risk, there's a lot more to stroke risk than degree of stenosis, right? So symptomatic disease, we use a lower threshold because those strokes can occur, you have a plaque rupture, but the degree of stenosis doesn't necessarily predict risk. And then there can be two patients that are both greater than 80% stenosis, and one person does fine and another person has a stroke. And I don't think we really understand those risks. We don't, using plaque morphology. For example, what do we do with a patient with an ulcerated plaque that's had a stroke, but they've got maybe 10% stenosis? What do you do with that patient? They don't meet criteria for intervention for any of the stenting trials, but we've ruled out other sources. We know that their carotid is the most likely embolic source. So,
Yeah.
I think a lot of food for thought there. And then what's optimal medical management? We still have a one size fits all approach. And we know that patients are different and morphology is different. So how about tailoring the medical management to the disease or based on plaque morphology, looking at the characteristics? Got a question from the chat.
I can read that. Dr. Hahn asks, there's a tremendous amount of variability from country to country. 90% of carotid interventions are done for asymptomatic in the UK. That number is only 50%. Carotid endarterectomy is still the most common procedure done in the United States, while in countries like South Korea, 99% of carotids are done with a stent. TCAR, oh, not a question, but that's okay.
Okay.
TCAR is also very US based without too much overseas use at the moment. While it seems like there is a standard, there really isn't, and I agree with the panelists. Thank you, Dr. Hahn. And thank you to both of our panelists for being here. Can we go to the last slide, please? Can we click to the last slide? Thank you so much. Awesome. Thank you very much to our panelists, Dr. Wohlhauer and Dr. Hayek, for being here. Thank you also to Dr. Hahn, our VESS VSIG advisor. Thank you to all of our attendees If you enjoyed tonight, please fill out our feedback form at the QR code there. And if you are interested in becoming a member of the VESS VSIG, please email or message through one of our social media platforms listed on the right-hand side. Thank you, everyone.
Nice job, guys. Have a good night.
Great job.